Did everybody get a set of slides?
Yes.
I'll take the first few and you guys help me out, especially with the diagrams.
Okay. And I can do the opening, Dr. Maxey.
Okay.
Hello, everyone, and welcome to this edition of Black Health Trust. And I would like to turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone. I hope everybody's had a early and good beginning to the new year. And Dr. Walks and I both went to church this morning.
Yes, we
A
did.
few thousand miles apart, but we went. So our text today, I'm talking like a preacher. Our text today, we're going to talk about something that's of interest to me as an internist, that every day I see patients and they don't know exactly the medication and the treatment that they're taking. So we're going to take our time and discuss some of the effects of the medication that can help you and can harm you, so we can talk about what to do. I'm going to ask my co-moderators to assist me as we go along. And the first slide, if you show it, Simon. So we're going to talk about the most common prescription medications in the United States, what their benefits are, their risk, and what the alternatives to them might be. Next slide. So the most common medications are to treat hypertension, pain, diabetes, cholesterol, sleep, and anxiety. Next slide. So let's talk about some abbreviations and some definitions. ACEI means angiotensin converting enzyme inhibitor, and that's a blood pressure medication that helps lower your blood pressure. ARB, that's an angiotensin receptor blocking agent. It's similar to the ACE inhibitor, but it also lowers blood pressure. NSAID, that's a non-steroidal anti-inflammatory drug, and that is for pain and fever. That includes things like aspirin and ibuprofen. Congestive heart failure, CHF. Congestive heart failure means failure of the heart to pump enough blood. CKD stands for chronic kidney disease. SSRI means selective serotonin reuptake inhibitor. And that's something that works on your GI tract, and it's a drug that helps treat you psychologically, psychiatrically rather. GFR means glomerular filtration rate. That means the rate at which urine is removed through your kidneys. Simon, let's go to the next one. So the natural oral origin, most medications, most drugs that we know come from natural sources. Aspirin, for example, is derived from willow bark. Statins, which are used to treat cholesterol, are derived from fungal metabolites. Natural does not mean safe. Don't think just because something is natural is safe. Arsenic is natural, but it's not
Yeah.
safe. If anybody listened to the conversation before we started, scorpions are natural, but not safe, Simon.
No.
Uh, Supplements may interact with prescriptions, so you should know when you take those vitamins, those pills from the drugstore, they may have an interaction with prescription drugs that you're assigned to take by your provider. Next slide. So, uh, Dr. Walk, would you take this slide?
Yes, sir. Hypertension. and treatment with ACE inhibitors. The mechanism is to decrease angiotensin II and to get vasodilation. The benefits, you decrease blood pressure, you
Okay.
decrease proteinuria or protein coming through and out of you in your urine, and decrease cardiovascular risk. Harms can result with a cough, hyperkalemia, AKI, and angioedema.
AKI is acute kidney injury.
Ah, okay. Contraindications, pregnancy, bilateral RAS, which is Dr. Maxey.
That is renal artery stenosis.
Okay. And then interactions, NSAIDs, comma, potassium supplements. And I just want to say that what you just saw demonstrated was why you should go to your kidney doctor for your kidney issues and not your psychiatrist. I don't have all of the abbreviations worked out that Dr. Maxey knows. I may know a few that he doesn't know, but certainly on the kidney side of the street, it's important to have the right doctor working on the right thing. Next slide, please.
Go ahead and take that again.
All right. Hypertension, ARBs. Mechanism, block the angiotensin II receptor. Benefits, blood pressure control without cough. Harms, hyperkalemia and acute kidney injury. Contraindications, pregnancy and interactions, NSAIDs, and case-sparing diuretics.
So it's very important to know that all of these are to treat hypertension, and the research on the ACIs were not done on Black people. And there is a lot of allergic reactions, laryngospasm, and problems with that. So we prefer to use ARBs. Those are drugs that usually end in the word sartan, losartan, and like that. Let's go to the next slide. Dr. Hines, will you take the next one?
Sure. Hypertension calcium channel blockers. So their mechanism of action is to block the calcium influx into your smooth muscle, and blocking that calcium influx will keep the muscles from contracting. The benefits are stroke reduction. The harms are edema or swelling. They can sometimes cause constipation because, again, if you think about muscles contracting, right, that's how things are going to move through your gut. So if the muscles aren't contracting, then now you're constipated. Bradycardia, which is a slow heart rate, and they can have interactions with grapefruit and beta blockers.
So that means if you're taking a calcium channel blocker, that you don't want to eat grapefruit, which I love. So be careful how you do that. And also, many times doctors combine those with beta blockers. I don't recommend that beta blocker be first line treatment for Black people. There's some literature that goes against supports what I'm saying, but also we know that beta blockers slow down the heart. So it can be a second or third line treatment, but should not be first line treatment in Blacks. Let's go to the next slide. Is Dr. Lawson on?
I don't see Dr. Lawson as yet.
Okay. If you go ahead with this, Dr. Watson.
Hypertension medications, benefits and risks. The ACIs and ARBs lower blood pressure, protect kidneys, reduce heart failure risk. Calcium channel blockers are effective for blood pressure control, but edema is possible. Diuretics reduce fluid overload. There's an electrolyte imbalance risk and potential harms, dizziness, kidney injury, and electrolyte disturbances.
Okay. A comment I'd like to make, Dr. Walks, about these diuretics and with the calcium channel blockers. When you get edema or swelling in your legs from calcium channel blockers, is not something that'll work that you can give a diuretic and it'll go down. So you have to use either compression stockings or lower the dose or look for another agent to do. And also we have to worry about being hyponatremic with electrolytes, with diuretics, with the sodium being too low. and it can get low enough to be dangerous. So we have to be careful with that. Next slide.
So Dr. Maxey, before we leave that slide, I just want to make a comment that so much of what we're talking about are folks that have already gotten into trouble with their blood pressure being too high, with some challenges with their kidneys and what have you. And for those who are not there yet, look at all of these slides as things to avoid. Do the best you can to not have to worry about all of this by staying as healthy as you can. We can't all be young like Dr. Hines, Dr. Maxey. So we got to try to prevent some of this.
Okay. Dr. Hines, you take the next slide, please.
Yes. Hypertension medications, benefits and risks. ACE and ARBs lower blood pressure. They protect your kidneys and they reduce your heart failure risk. Calcium channel blockers are effective for blood pressure control, but some calcium channel blockers can also cause edema or swelling. Diuretics will reduce your fluid overload, but they can cause a risk of electrolyte imbalance. And the potential harms are dizziness, kidney injury, and electrolyte disturbances.
Next slide. We take this, Dr. Hines.
So blood pressure reduction, meds versus lifestyle changes. So, I'm gonna guess that the bottom is the amount
No.
of reduction in systolic blood pressure, maybe?
Yes.
Yes. Okay. So the ACEs and ARBs can cause the greatest reduction or change in your blood pressure, followed by diuretics. And then the DASH diet or dietary changes is right after that, right? And then following those are going to be exercise and weight loss. So depending on how much you need to reduce your blood pressure, there is always a role for therapeutic lifestyle changes like diet, exercise, weight loss, but sometimes that may not be enough to get you to the goal, depending on where you're starting from.
Dr. Hines, would you comment on systolic versus diastolic blood pressure? And
So the top number is called your systolic blood pressure, and that is the pressure in the system when your heart contracts, right? So that's that top number. That's supposed to be around 120, right? And then the bottom number, which is called your diastolic blood pressure, is a reflection of the pressure in the system when your heart is relaxed. Sometimes people focus just on the top number, and as long as their top number is fine, they think they're fine. And it's common to want to do that because the top number is sometimes the more dramatic. Oh, it's 180, it's 160, it's, whatever. And then your bottom number is supposed to be, 80 or less. So when it's 90 or 92, it doesn't seem as dramatic as 170 or 180, but it's a problem as well. So you can have heart dysfunction that is related to diastolic issues, right, just as much as it is related to systolic or the top number issues. Translation: both numbers matter. Both numbers need to be at the goal for you to have controlled blood pressure.
And let me make this comment. For Dr. Hines, at her age, the diastolic is probably more important to her. For Dr. Waltz and me, the systolic is probably more important because of our age. That's something that's relative, but as you get above the age of 50, that systolic pressure gets to be more. But when you're a teenager, that diastolic is not quite as important. Is not quite as important. So Dr. Hines is a teenager. Next slide.
I'm just lucky that I have a blood pressure, Dr. Maxey.
Okay, Dr. Hines, you can take this one if you would.
So congestive heart failure medications. So ACEs, ARBs, and ARNIs are used either in combination to reduce mortality. Mortality is the rate of death, right? Beta blockers are known to improve survival for those who have congestive heart failure. Diuretics, they are reducing the fluid in the system, so their greatest benefit is in relieving some of the symptoms that come along with congestive heart failure. So and then just to back up a step, congestive heart failure is basically when your heart, which is the pump, right, that's supposed to be helping the blood move through the system, is no longer working effectively as a pump. And so blood can get kind of congested or pooled because the pump is not working effectively, and that can lead to all kinds of complications, including swelling, changes in your blood pressure, shortness of breath, fatigue, those types of things. So that's where these combinations of medications are used to both prolong life as well as quality of life and dealing with symptoms. But there are risks associated with using them, and that can be things like low blood pressure and kidney dysfunction. When congestive heart failure progresses to a more serious level, it can be very hard to strike a balance between getting enough blood going through the system strongly enough, while at the same time making sure that all of the organs that the blood needs to get to are getting all of the blood that they need to. So it can get really tricky when this gets to a more severe state. So as Dr. Walk said earlier, prevention is key.
Okay, next slide, Simon. So there's some core medications that go along with congestive heart failure. The ACEs, the ARBs, and the ARNIs, they decrease remodeling. So when heart failure first starts, the heart starts to get thicker. And there's something called afterload. That is the pressure that the heart is pumping against. And like a muscle, the heart originally starts to get thicker and more muscular. And as it goes on, it'll start to remodel and get thicker, and then it'll start to fail and get flabby and won't pump nearly as much. Beta blockers in congestive heart failure, they decrease the sympathetic or adrenergic toxicity, and they slow down the rate of the heart. They decrease the heart work and oxygen consumption, so it's less toxic from that. MRA, that's something that affects your adrenal glands, and also the SGL2. Those things like Farxiga, they decrease mortality from heart disease and also stroke, by the way. But their risk of hypotension and hyperkalemia, which is high potassium, which is toxic. Next slide. So chronic kidney disease is something that's very important to me. We want to avoid or limit NSAIDs. We've talked about those a bit. We want to dose adjust if you're taking gabapentin for pain or if you're taking metformin for your diabetes. We prefer that you use ACEs and ARBs, but monitor them. You can't just give them willy-nilly. You have to be careful with them. We also want you to avoid magnesium and potassium overload. So be careful eating bananas and greens with moderation when you're on those drugs. And always review or know something about your glomerular filtration rate, how well your kidneys are functioning. Next slide. Dr. Wilkes?
Pain and arthritis medications. The NSAIDs, they reduce pain and inflammation. The major risks are kidney injury, gastrointestinal bleeding, heart attack, and stroke. Safer options in chronic kidney disease and cardiovascular disease are acetaminophen and topical NSAIDs, as well as physical therapy. Next slide, please. Okay.
Good.
Arthritis and NSAIDs. Mechanism, COX inhibition, benefits, pain and inflammation relief, harms, gastrointestinal bleeds, cardiovascular risk, kidney injury, contraindications, chronic kidney disease, and congestive heart failure. Interactions with anticoagulants and with steroids.
Next slide. Take the next few, Dr. Hines.
What are NSAIDs? So NSAIDs are used to reduce pain, fever, and inflammation. They stand for non-steroidal anti-inflammatory drugs, right? And examples of those are going to be things like your ibuprofen, your naproxen, your Aleve, your Motrin, and aspirin.
Take the next one if you would.
And how do they work? So they block an enzyme called COX, C-O-X, and that reduces, by blocking COX, that reduces prostaglandins. Prostaglandins are responsible for triggering your system for inflammatory reactions. So it then reduces inflammation and subsequently reduces pain.
Go ahead and take the next.
So there are risks associated with using NSAIDs, and that can be things like stomach ulcers and bleeding. And that has to do with those prostaglandins that got blocked. They play a role in your stomach and in your stomach lining. So that is why sometimes there's a risk of, when you use them too much, of stomach ulcers and bleeding. And then they can also be linked to kidney injury, as well as heart attack and stroke risk. So I feel like, lots of times we hear aspirin as, heart protective, right? So while simultaneously calling it an NSAID and saying that there is a risk of heart attack and stroke risk. So I would say that is usually more associated with the ibuprofens and the naproxens than the aspirins. But again, depending on the type of stroke risk that we're talking about, aspirin could be a risk in that space too. So translation, use those things. If you have those types of risk factors, you want to make sure that you're using those medicines, even though these are things that are available over the counter, and most of the other things that we've been talking about were not things that were available over the counter. Just because it's over the counter doesn't mean it's safe to use without discretion.
And I always tell people, eat something when you take the ibuprofen or any of that, even if it's a piece of.
So I just want to clarify, Dr. Maxey. So just because someone who is in a very high political position says, I take more aspirin than my doctor says I should because I want my blood to be thinner, that doesn't mean that the rest of us should just willy-nilly take a bunch of aspirin.
Well, some people would say if a certain person says go right, you should go left.
But I do think that there is something to that, even for the general public, with regard to the idea that sometimes I've taken, the two things, the ibuprofen, so I'm gonna take some more because I'm still in pain, right? So there is this thought that more is better, right? And the reality is more is not always better. There are times when more is better, but that not necessarily. And then when it comes to things like your Tylenols and your NSAIDs, the reality is at some point, the receptors that are going to be able to target or deal with or absorb the medicine that you're putting in, sometimes you're not going to get any more benefit. You're just going to get more side effects. So some of the home titration that we might be doing because we think we know what we're doing can sometimes put you in a space to get some of these side effects, because maybe the reason why it wasn't enough is because that wasn't the right medicine for you, or the problem is deeper than something that can be addressed with, NSAIDs, or any number of reasons. But just because it's over the counter, don't just assume that it has this safety window that will allow you to do more.
Okay, go ahead and take the next slide if you would, Doctor.
So ibuprofen or Motrin. So that is a common NSAID. It is good for short-term anti-inflammatory pain. Think, backache kind of thing, or, maybe I sprained my ankle, that kind of thing. You want to avoid using NSAIDs like ibuprofen if you have chronic kidney disease or known heart disease.
Next slide, Simon.
So what about acetaminophen or Tylenol? That is not an NSAID. It is not an anti-inflammatory, but it does help with pain and fever. If you notice, it doesn't have that anti-inflammatory benefit that we mentioned with the NSAIDs, and that's one of the things that makes it different.
And this was recently in the news. You want to speak about that? What?
So, assuming that we're talking about the same recent, Tylenol or acetaminophen was relatively recently attempted to be linked to autism and autism spectrum disorder, but there is absolutely no evidence that that is true. And if you look at the wording that they put on the CDC website, they phrased the sentence in a way where you could put anything in the front and have that sentence be true. I cannot think of it off the top of my head, but it's essentially, it said something like, there's no evidence that Tylenol doesn't cause autism. Well, I could fill that in with anything. There's no evidence that sunlight doesn't cause autism. There's no evidence that green grass doesn't cause autism. That sentence is not based on how science works, right? It is phrased in a way that is meant to allow propaganda to be put out there and to cause concern where there isn't any, because the way science works is we don't rule out all manner of anything possible that could be potentially linked, because that would be infinite. But just be mindful about when you're reading some of these things that are coming out, especially with our current administration, look at the way that even the way that the sentences are put together, because that sentence is a true sentence. There is no evidence that Tylenol does not, that Tylenol doesn't cause, or I can't remember how it's worded, but again, the point is you could say that about anything.
There's no evidence that scorpions cause autism either, right?
Exactly, right? Exactly.
Next slide.
So,
stay on this with acetaminophen for a while. You keep going.
Yep, how acetaminophen works. So it acts mainly in the brain, and it has minimal impact on your stomach or minimal impact on your kidney function.
Next slide.
So, but it does have risks, right? So Tylenol overdose is a thing. So liver toxicity is a real and potentially fatal issue with overuse of Tylenol. And then you want to be especially cautious if you have alcohol or alcohol related liver disease or alcohol use disorder. I think other than the people who are intentionally trying to harm themselves, but with Tylenol, the places where I think people get into trouble is oftentimes, in my experience, when you don't even realize that you're taking too much Tylenol. Think about when you're taking your cold medicine, right? And maybe you already take some standing Tylenol arthritis, 3, 4 times a day for my joint pain. But then I'm also taking my cold medicine, which I didn't even realize also had Tylenol in it. And that is sometimes how people can get into trouble with taking too much Tylenol in particular. Sometimes the same thing can happen with NSAIDs as well, even though it's not necessarily an overdose issue, but it can lead to some of those side effects. So you have to be careful about making sure that, again, we're talking about over-the-counter medicines, making sure that you are reading the ingredients and not unintentionally taking duplicate doses of the same medicines.
Next slide.
So a side-by-side comparison. So NSAIDs work on pain and inflammation, and acetaminophen is just on pain.
Next slide. So we know that gabapentin, which is also used for pain, can affect calcium channel blockers, so you have to be careful when you're taking those. Serotonin reuptake interact with monoamine oxidase drugs. Be careful of that. Your doctor will probably help you with that. Opioids. There's a certain mu receptor that affects the opioids, and that's an addiction thing. And the risk of those types of drugs are all sedation and as well as addiction. Next slide. So pain relief and versus kidney and heart risk. This talks about the NSAIDs. It shows that there's more likely to be a risk more than the pain relief using NSAIDs if the person has chronic kidney disease or heart disease. We also can see that with acetaminophen, there's better pain relief and less side effects with that. Gabapentin, the same thing, and the same thing with topical and NSAIDs or other gels that can help you. So don't put it in your mouth, put it on your skin for pain. Next slide. Dr. Walks?
Sleep and anxiety medications, benzodiazepines. Short-term anxiety relief, there is a dependence risk with the Valium, Librium, alprazolam. Those are examples of the benzodiazepines. Sleep aids, zolpidem, trazodone, sedation, and fall risk. There is something that people describe as a trazodone hangover. So you take your trazodone at night, you go to sleep, you get up in the morning, you're still not completely over it or away from it or back to normal, and people can fall or get up in the middle of the night and fall down. Some of the alternatives are CBT1, cannabinoid, magnesium, and melatonin with caution. Next slide, please. And this is a similar slide to the one we just saw, sleep improvement versus adverse effects with the zolpidem. You can see some good sleep improvement, also significant adverse effects with the benzodiazepines. You can see sleep improvement, but the adverse effects, particularly the risk of getting accustomed to it, doesn't work as well anymore. And the addiction and dependence kinds of things are really significant. And then melatonin, less so with that. And the CBT1, again, less so with that. Okay. Sleep disorders. Oh,
Go ahead.
okay. Sleep disorders, medications. Trazodone works through serotonin modulation. The Z drugs, BZDs, work through GABA enhancement. Again, we're talking about risks such as falls, dependence, and confusion. Next slide.
So interaction with is very important. So we know that foods and supplements can raise or lower medication levels. This may cause treatment failure or dangerous side effects. Next slide. So we know that there's some high-risk food interactions. Grapefruit used with statins or blood pressure meds may increase the drug effect. So it's very important not to eat grapefruit as much if you're taking some of those ACEs and ARBs or statins. We know that leafy green vegetables interact with warfarin to cause a decreased effect. Now, warfarin, which I call rat poison, is something that thins your blood, but it can cause bleeding. But it helps people stop getting pulmonary embolus and thrombophlebitis, and it will decrease the effect of that. So you have to monitor what you eat. We know that tyramine foods plus MAO inhibitors increase hypertension, can give you a hypertensive crisis. So that's very important. Next slide. So relative risk, warfarin plus vitamin K foods have a high risk. Statins plus grapefruit is a moderate risk to high risk. NSAIDs plus ACE inhibitors have a moderate high risk of causing hyperkalemia. Next slide. Dr. Hines, you take this one?
So the relative risk of medications with various food interactions. So If you take warfarin with vitamin K, there is a significant risk of an interaction that leads to increased thinning of your blood, right? Which leads to increased bleeding risk. When you take statins and grapefruit at the same time, there is 3 times the risk of interaction in that space. When you take NSAIDs with ACE inhibitors, there is 2 times the risk of having a side effect, right? With regard to your kidneys. And then if you take metformin and food, there is a 1 time risk, which is relatively neutral.
Next slide, Simon.
So
Go ahead.
drug levels, okay.
Go
Drug
ahead.
levels over time. So there's your normal metabolism versus your grapefruit induced metabolism. And that can lead to higher peaks, which leads to a greater toxicity risk.
I think it's on the graph. Next slide.
So the red line is your drug levels with grapefruit on board. And then the blue line is your drug levels without grapefruit on board. And as you can see, it peaks higher around that 2-hour mark. And that peak could be the place where you're getting more medication in your system than you need.
Next slide. So, natural products versus prescriptions. We know garlic, turmeric, ginseng, and St. John's wort, they can interact with blood pressure meds, anticoagulants, as well as antidepressants. That first line almost sounds like one of my recipes with ginseng and turmeric and garlic. I cooked that. Next slide. So kidney and heart safety. We have to be careful with NSAIDs that gives you high kidney and heart risk. It's something to know. Acetaminophen can be a safer alternative than NSAIDs for pain. And gabapentin, you have to dose adjust that if you have chronic kidney disease. Next slide. Dr. Walks?
Take home messages. Natural does not equal safe. We talked about this earlier. Ask before adding supplements. CKD and heart patients need extra caution. So if something is already a challenge for you and you're already being treated, then absolutely you have to ask all of these questions and let your doc know, because natural does not equal safe. Visual, do, avoid, ask icons. Okay, we're going to get some do, avoid, ask icons. Next slide, please. Oh, takeaways for patients. Medications provide benefits, but carry risks. Kidney and heart disease require special caution. Never stop or combine medications without medical guidance. Lifestyle changes can amplify medication benefit. Or can I just add, lifestyle changes can reduce medication benefit. If you start going the wrong way with your diet and with your exercise, don't expect the medication to make up for that. If your New Year's resolution is to take more medicine and eat more fried foods, that might not be a good combination.
Next slide, please. Go ahead,
Dr. Maxey. Key takeaways.
Understand the mechanism. Go ahead, you take it.
All right, understand the mechanism. Understand how things are working to predict benefit and harm. Natural products are or can be adjunctive, and always, always, always assess interactions and comorbidities. How were the medicines and stuff going to interact with each other? And what else do you have going on that may cause the medications to act or interact differently? Next slide, please.
I think that's the last.
Okay.
So I think the key thing that we've talked about in here is that be careful what you take. Have some idea, not just you got a blue pill and a red pill. Have some idea what it's doing and what the contraindications are. Ask your doctor questions. Read the labels good. And most medications come with an insert with patient instructions. Take time to look it up, to read it, so you don't make a mistake. But discuss them with your provider who's giving you medication. Don't just listen to Miss Rose on the TV and just take what she says. Know what to do. And just because someone says it's natural doesn't mean it's good for you. It can be, but it may be a scorpion. Any questions, any comments in the chat, Dr. Walks?
I don't see any. There's a lot of scorpion information in the chat from our conversation before we started, but I think the information that was put together today, Dr. Maxey, was really very, very clear. So I don't see any questions in the chat.
Dr. Gibson has his hand raised.
Dr. Gibson?
Thank you. I just wanted to remind people that you have a whole host of information that's a lot closer and a lot easier for you to access than you might ever think. Just walk into any, well, not just any, but most pharmacies and talk to the pharmacist, even if you have to make an appointment. And most times you won't have to make an appointment, but talk to someone. If you have a question, ask the question. There's no such thing. Well, the only dumb question is the question that you don't ask. Now, there are some very, very, very important things I will cover today, especially as it relates to inflammation and the treatment of same. I would say prophylaxis or prevention is even better when you do things like modify your diet and such so that you can offset inflammation. Along with avoiding inflammation, you can have much better outcomes and much less pain, because it can be a very, very slippery slope, especially when you have cardiovascular issues and also when you have chronic kidney issues. The aspirin is one that is full of controversy, as they say, across the pond, and really needs and deserves careful, very, very careful attention, because it can provide life-saving, and I dare say life-saving benefit in certain cardiovascular situations. Please let me reiterate. Sometimes patients might just need an aspirin when they're in a pickle and they're having serious cardiovascular issues. That has to be carefully, shall we say, balanced with other medications. You need to know, if you're going to make that kind of intervention, you need to know what other medications that patient might be taking. But on the other hand, the inflammation, sometimes we can, by use of certain, dare I say, natural products like the turmeric Dr. Maxey mentioned, we can deal with the inflammation in very effective and efficacious manner. Lastly, what I'll say is moderation is key. You know, when you really, really don't know what you don't know, and that's more often than not, whether we happen to be trained or not, be careful, because medications, even though, like Dr. Walks said, even if it's over the counter, it doesn't mean it's safe. It doesn't. It doesn't mean it's safe. And it could even be a vitamin. And if you take too much vitamin K and you really don't know what you don't know about that vitamin K, because it's going to be hidden with a whole bunch of other medications, you could find yourself in trouble. Anyway, I maybe I overstretched my time, but I yield.
Actually, I want to ask you a question.
Yes, sir.
We're about in the season for Lent, and at my church today, they're starting something called a Daniel fast tomorrow. And I said, I want to do that. But I
Okay.
also know that a lot of people are diabetics and they take insulin and
Mm-hmm.
all other
Mhm.
kind of medicine. How would doing that fast, how would you do that in a diabetic, and what concerns would you have that they need to be mindful of if they
Because, sorry.
if they take insulin and other medicines to
Y-
control their glucose?
Yeah, because that one is so very delicate, especially when the patient is to the point where they need insulin support. I would not, I repeat, I would not start that without some short or maybe even not so short conversation with the physician. Because there's
Yeah.
no way for me to address that one because it's a whole host of effects that can come, and people don't understand that. And Hippocrates said it best. Yes, that same Hippocrates, let thy food be thy medicine, let thy medicine be thy food. So, when it comes to medications, talk to your physician. And Dr. Walks, Dr. Hines, and Dr. Maxey will be the first to tell you, hey, maybe this, not that.
Good. The other thing I want to mention, and maybe Dr. Hines might want to comment on, um, we've we've sort of talked about how bad NSAIDs are, but recently been a change in the use of some of the NSAIDs. But previously, we were advising people to take 81 milligrams of aspirin daily, and that was to be used as a mild blood thinner. It's no longer recommended. But if you have chest pain and you suspect somebody's having a heart attack, some people might recommend you still, if you have an 81 milligram aspirin, that you can chew it. But we know now that that low dose of aspirin is better to prevent some types of colonic cancer than that. But if somebody is having chest pain and you suspect an MI, would you take an 81 milligram aspirin or any aspirin while the paramedics are coming, Dr. Hines?
So 100%. Like if I had a real strong suspicion that I'm at my house having Thanksgiving or whatever, and we have a family member that is having some signs of an acute MI, absolutely. And I'm not gonna, and if it's 320, because most people don't even have 81, right? Most people have 325 at their house because that's what you get at the store. We would absolutely take that and then hope for the best, because in an emergency, right? You do the best things you can do in an emergency. But at the same time, that's not what we're talking about primarily here. We are talking about things where you have the opportunity to think, prepare, and plan for what it is that you want to be taking. I just wanted to circle back to that turmeric comment earlier, and then there was a question in the chat about is turmeric or curcumins a alternative to NSAIDs?
Before you go there, this why we're on this aspirin thing. I think the recommendation is that you chew it at the time of that chest pain, not just swallow it.
So it is depending on what you have, right? Because some people have the enteric coated versions at home. Some people have a lot of different types at home. But I would agree with you. And the reason for the chewing, right, especially if you have the enteric coated, is so that it can get into your system faster. But the point that I think I was just kind of get to is I don't know if aspirin comes in capsules, right? But if it did, then that's same thing. The point is take some, right? Do the best you can scenario. And chewing, the reason he's emphasizing chewing is because it allows your body to absorb it sooner.
Okay, go ahead with
the comment that I was going to make about the turmeric is there are a lot of studies being done with regard to turmeric as an anti-inflammatory, and it has been recognized as an anti-inflammatory that in some instances can be used alongside NSAIDs, used as a replacement for NSAIDs. But here's the thing, it works in a similar manner, right? It is a COX inhibitor. So depending on what the reason is that you may be trying to get rid of or stop being on NSAIDs, turmeric may or may not be the best alternative for that. I would also say turmeric in and of itself, your body doesn't absorb it very readily, which is why you'll see it in commercial preparations along with other things like black pepper and stuff like that. So again, this goes back to where we started. Just because something is natural doesn't mean it's benign, right? Or doesn't mean that you don't have to put thought into whether or not it is a good option for you as an individual. Yes, turmeric has been in the studies that are available, they have found it to be have a reduced side effect profile, but they also haven't figured out what's the optimal dose either. So there's still work to be done. And I would say when you are, because the social media world is has an abundance of people trying to sell you natural remedies for any ailment you can think of. When you are doing your internet searches to try to hopefully do some research on what this very popular and charismatic individual may have said to you that's going to be a cure-all for everything you've got, right? Make sure that you are asking your computer, your AI, and lots of times even your regular old Google search doesn't work like it used to. You have to ask for, is this thing scientifically backed or scientifically proven? Because lots of times your AIs will just repeat whatever the popular discourse is. So if the popular discourse on the internet, because remember, it's just scanning the environment and finding out what people are talking about. If the popular discourse is that turmeric is the best thing on the planet to reduce your inflammation and arthritis pain, there's a good chance that if you just put it in like that, then it's going to tell you, yes, go ahead, take turmeric, right? But ask it, is it scientifically researched, right? Are there side effects? Ask it a more detailed questions that then you can be, and that's not just for turmeric, but for any of these magical remedies that are snail slime. I mean, the colostrum's back in again. Like all of these things are coming up because people are trying to monetize things. So just make sure that you're nobody's victim because somebody was trying to monetize.
Well, thank you so much. I appreciate your insight, my young teenager doctor.
So Dr. Maxey, earlier, Lajai Marks had her hand up and she put it back up again. And then also Dr. Sherrod has her hand up.
Okay, let's recognize them both. Who's first?
Hi, good afternoon. Thank you all so much for your input regarding my question. I had lowered my hand before because I had heard it be addressed and then I heard it be addressed again. And so I wanted to specify that I was asking not only about turmeric, but also curcumin, which is, you know, the active ingredient within turmeric that's responsible for the anti-inflammatory effects. So I was asking not from a lens of a social media or Google search, but, from science. The research is not new. I was wanting to know specifically if the Black Health Trust endorses it, because I know that there's, even certain medications, although they're generally endorsed, right, by the public, you don't recommend for our people, right, that might not do well for us. And so I was curious because it's pretty well known, especially in orthopedic spaces and physical medicine spaces, that curcumin and turmeric, are recommended supplements, but I was wondering if you all endorse them for us, was the question.
Well, being a not-for-profit, we can't really endorse something, but we can say, check with your provider and your physician or nurse practitioner that you have confidence in. But it's beyond us to endorse something specific. But the fact that we've talked about it means that a lot of us use it and recommend it, and I cook with that myself, especially the turmeric. Dr. Hines, you want to comment?
Yeah, I think within the confines of things that we can say, to your point, I second your point, right? There is plenty of scientific evidence that supports that there is a valid role for turmeric's use as an anti-inflammatory agent. And I think like with all the things that we've covered, you just have to be using things in a reasonable fashion and recognizing that, again, it can be beneficial and too much of a good thing can also sometimes be harmful.
And for anybody that's not a vampire, garlic is very good too.
Listen, as Dr. Gibson pointed out, the fact that food is medicine and let your medicine be your food, that has been true for forever, right? It just so happens that we are circling back around, I think, in the medicine and scientific community to reinforce and to remember, right, that the role of your gut and the things that we're putting into your gut and the bacteria that's supposed to be there and all of these things that have been around and forever carrying different names, right, that are encompassed in having a healthful diet, right, in all these different scenario settings, be they cultural settings or geographical settings. There's a reason why we have evolved to do some of the things that we do.
And Dr. Sherrod?
Oh, okay. Good afternoon. Again, Dr. Maxey, this was a really nice session. Thank you for it. And just want to make one big comment about the Imhotep statement of let the food be the medicine and the medicine be thy food. Actually, Imhotep said that before Hippocrates. Hippocrates, of course, gets the credit for it.
Say that loudly again.
Imhotep said that before Hippocrates. But anyway, I want to emphasize that all medications have side effects. And in this environment that we're in now with all these supplements and vitamins, I just want to reemphasize the necessity of consulting with your provider, being transparent about what you're taking, because there can be some serious interactions. And as a pediatrician, I also want to emphasize following the recommended doses of Tylenol. I had the opportunity of actually sitting on a deep dive committee on Tylenol back in the 90s when I was on the ACIP. And it is very toxic for the liver. And you really do have to stick with the recommended dose. And I know as pediatricians, we use it a lot in combination with aspirin, alternating, trying to control fever. So I want to just emphasize, please follow the directions on the bottle for use of Tylenol because it can destroy your liver and actually can be deadly. But again, I thank you all for all of the great information. And like Dr. Hines was saying, you can Google a lot of stuff and get a lot of information, but you need to make sure you can integrate that information properly. And so it's good to let your physician know what you're doing.
Thank you, Dr. Sherrod. Let's go we're at the top of our hour. Let's go with our final comments. Dr. Hines?
This was again a really timely discussion. I think that with as I was saying earlier, the environment is ripe to have a lot of things put out there. And where we started with just because it's natural doesn't mean that it is without consequence, right? I'm not even going to use the word safe, but without consequence is an important feature. And as we've always said on here, be forthright and upcoming about some of the things that you are taking as far as your supplements and any significant dietary changes. Because as we pointed out before, like the role of vitamin K or grapefruit, right? That is not necessarily something that if someone says to you, what medicines are you taking, right? What you may not think about, I do have, grapefruit, that's my breakfast in the morning kind of thing. That may not be something that stands out. But if in this discussion, you've heard something that, kind of jogs your memory about things that you may do that you might want to bring up to your provider, make sure you have those conversations. Or as Dr. Gibson also pointed out, your pharmacist is also another good resource too.
Excellent. Dr. Walks?
Thank you, Dr. Maxey. Long time ago, when I was in the military, I was in basic training, and we had to keep a money list. So you had to, any bill that you had to write the serial number down on a list and keep it in your wallet with your money. So if somebody stole your money or keep it someplace safe, you would have a list of what was yours. It was really important. We got in trouble if our money list wasn't constantly updated because they would check. Keep a medication list. There are few things more important if you have a problem than having the people who are trying to help you know what medications you're on. It just makes sense. Keep it. I know young people, I don't carry paper. Okay, put it on your phone. Have a little place on your phone that says medication list, and everything that you take, your prescribed medications and your over-the-counter medications and your supplements, just have a list of it with you. So that if you have any sort of a problem, you can in fact have the person who's coming to help you know what's already on board or what should be on board. And then in response to the question about what the Black Health Trust recommends or what we endorse, I think the primary thing that we try to do is to let folks know what the challenges, risks, and opportunities are with medications and medical treatment. At the end of the day, each of us should have an endorsement for our actual behavior from our primary practitioner. If that's your primary care doctor, if that's your nurse practitioner, if that's your PA, whoever that is that takes care of you, that person should look at your list of all the things you have as conditions and all the things you use as prescriptions, supplements, and other things. And that person should make a recommendation for what is right for you. We are not all the same. We're just not. And we come, to make a long story short, it's a very long and important story, but to make it very short, we should respect ourselves enough to make sure that what's being prescribed for us is for us.
Thank
Thanks,
you.
Dr. Maxey.
Well, so as a physician seeing patients every week, I encourage patients to bring a brown bag or a white bag with all their medicine in it, and let's go through it. Not everything that I gave you, everything everybody else gave you, and stuff that you picked up from your sister. Bring it, and let's go through it every time you come. And often you'll find very surprising things in there that are knocking heads. So it's very important to do that. And especially with men, I tell them, I know you know what kind of oil, what kind of gasoline you put in your car. Know what kind of stuff that you put in your body. It's more important. Thank you, everybody. Enjoy your Happy New Year. And we'll be back next week. Thank you, Simon, very much. And thank you, Dr. Hines. Thank you, Dr. Walks. And thank you, Dr. Gibson. And others that have commented. Have a great day.
Good day, everyone.